Hey, it's Matt Roush,
And Mike Brennan.
and we're back with another segment of the M Squared TechCast. Once again, joining us after a couple of weeks off, he's back from an illness that apparently was not COVID. It was just a plain old cold or something. Is Fred Brown?
Great to be back. Thanks. Yeah, I thought I might have come down with it because I had lunch with a guy who, works at a P3 lab, and he was working with live virus, and we were talking away, and all of a sudden I realized maybe he's asymptomatic, and I came down with some symptoms, but everything's fine now. So and it was not COVID. It only took 2.5 days to get the results back. So great job on you, Ben's part.
Okay.
Yeah, I was up. I took a week off. The last week in July, I went to West Michigan and got around a lot of friends. We even did a beach party, but not too close. And then, so when I got back, I did the COVID test at one of the drugstores, and it took almost a week to get the test back. So I'm thinking, God, this isn't doing me any good, right? So I guess that's one of the big issues right now is there are tests available, but if it takes a week or 10 days to get them back, they really aren't worth much, are they?
No, they're not. Actually, sadly. In fact, one of the main recommendations that we made as a steering committee was to have the government stop paying for tests that take more than two days to turn around. Because what happens is you are exposed. It takes about 5.5 days to get symptoms. So if you have but you can get tested after day 4 if you think you've been exposed and still have a pretty good result. At that point, if it takes 5 days to turn that around, you're only shedding virus from day 2 to day 12. Now, shedding live virus. What we found is that although people shed virus for up to 28 days, generally the live viruses are shed in the first 10 days after this virus gets established. Is about day 2. So between day 2 and day 12 is when you can actually effectively go into isolation and call people and say you've been, possibly infected. Once it gets beyond that, it's useless. And so our steering committee, back to CMS, which is reimburses for Medicare and Medicaid, recommended that we don't pay for tests that take more than 2 days to turn around. Right now, these large testing companies are raking in lots of money for tests that are completely unusable for the general public. So that's a big problem.
Yeah, because it would be 2 weeks tomorrow since I was at my event, and I didn't get my results back till Saturday night late. So I figured people were asking me, how'd your test results come out? And I go, well, I haven't got them, but I said by now I probably should have symptoms, because it would already been about 10 days at that point. And so I didn't. And
yeah.
Not to worry, I guess.
Well, I went and donated platelets at the Red Cross Blood Donor Center in Livonia a week ago Saturday.
Excellent.
And I'm supposed to get, with that, they said it was, they give you a free antibody test when you donate. And they said 7 to 10 business days. I'm like, well, okay, so it's not a test for live virus, it's a test for antibodies. So it's not quite as time critical there.
It's important to find out whether you've been exposed and whether you were asymptomatic. There are numerous examples, sadly now, of people who were asymptomatic, were exposed, had no conditions of COVID, no fever, and have come down with very serious conditions 2 to 3 to 4 weeks later. Things like Guillain-Barré syndrome, which can cause paralysis. A friend of mine actually came down with that after getting negative tests for COVID live virus, but about being positive for the antigen. And there are numerous examples of people with arising with cardiac problems. And so it's very important that you get the antigen test to see if you've been exposed at all. Because even if you're asymptomatic, that doesn't not change the fact that lots of things can happen downstream, and the severity of those downstream impact has nothing to do with your original COVID. So even if you are absolutely not sick, you can have very bad symptoms. If you're very, very sick, you may have no symptoms of other conditions downstream. So it's completely independent of each other apparently right now.
The hot topic now, well, obviously, I think you're on the call when the Big Ten canceled the football season, which I would have been surprised if they would have tried it, tell you the truth. And they were originally thinking, well, we'll just play the empty stadiums. But yeah, these guys are clearly breathing on each other, and they can't be 6 feet apart. I mean, this doesn't work out in football, right? So I was sort of surprised, but not really, because they're now talking about maybe hopefully next spring, just move it to spring football, which, be nice, because typically as the season wears on, you're freezing your butt off in the stadium. But the other issue going on is schools are around the country now are going back. I talked to a buddy of mine who's a teacher down in Florida, and they're starting on Thursday, but they're just doing all remote. They're not doing any in-person stuff. And this in Michigan, it's been a real mixed bag. Some are, some aren't. Some are going hybrid models. What are you seeing? Or what's your advice, I should say?
Yeah, so about half the schools are trying to open, and about half of them are trying to do either a hybrid or remote only. About 35% are remote only, and 15% are hybrid. So that's sort of the general disposition right now. That could change rapidly. I think what we're going to find is that we're going to have a lot of trouble opening successfully. And when we look at the challenges that we're having in Georgia, Florida, and other areas that are opening earlier than we are, we're going to look back at that and say, we just don't want to take the risk anymore. I think if you have to open a school, we're kind of doing it backwards. The first area that we're worried about is like University of Michigan football. Actually, those are the schools that can probably most afford and best teach people remotely, if you think about it. Whereas it's the young kids who are trying to learn math for the first time and reading for the first time. Those and they don't transmit as much virus because they don't breathe as heavily and they don't have quite the same load, although pretty close, sadly, until the age of 10 of the virus. So if I were a policymaker, I would look very closely at probably trying to do high school, where you have lots of switching of classes and mixing of different people in big hallways. And, we saw that big picture of Georgia, I guess, where they had lots of mixing of people that didn't look good without any masks. I would definitely require masks at all times. And I would try to move towards surgical or N95 masks, not just cloth masks that your mom makes in your basement. And I would also have, once we get testing better, at that point, we'll be able to do this a lot more safely. But right now, very few states are in a position to in fact, really no state today is able to test sufficiently to mitigate a virus and really understand what the spread looks like, unfortunately.
Matt, what's the status with Lawrence Tech? Are you guys going to go all virtual or hybrid? What?
It's pretty much a hybrid at this point, although we have said that we're going to be flexible depending on what happens. You have to be. But all of our graduate courses are going to be online this fall, except for a few engineering labs and architecture studios. And the undergraduates, we are planning on having them come back, but our class sizes are pretty small. We have an 11-to-1 student to faculty ratio. And after freshman year, especially, most of our classes only have 10 or 15 people in. So it's pretty easy to be in a lecture hall with 6-foot social distancing on a basis like that and a mask requirement. We are planning on reopening the dorms and the cafeteria. Unfortunately for the environment, that means going to all disposable everything, basically, in the cafeteria. So, and a lot of box lunches, I would bet. But, right now we are planning on bringing the undergraduates back for in-person classes, although if there's an outbreak, if the numbers start spiking again, we'll have to go back to what we did in March. You got to be responsible and safety first. So
yeah, as tricky as it would be to have students in a classroom, having them in a dormitory, I mean, that's a whole nother thing there. I mean, you're sharing everything in a dorm, right?
Right.
And
there's going to be they're laying in massive supplies of sanitizing stuff, and at this point. We're just hoping people are responsible and don't have big house parties and things like that.
The off-campus housing is even more concerning, actually, because they have even less control in some ways.
Yeah. Oh yeah.
Parties and pong and going shopping.
Yeah, and we've got only about a third of our student body lives on campus. The other 2/3 is off campus. So that's
Same with you.
You really can't control what they do off campus, but you just have to hope they're responsible and follow the CDC guidelines.
Yeah, I remember when I was an undergraduate, mingling, as it were. I mean, that was just what you did, right? I
All
mean,
weekend long. Yeah, you bet.
yes, no mingling this year. So, what are you saying? I mean, the superintendent of schools or something would ask you a question. Should we do what? What would you say to him?
Um, let me show you a little bit of what we're doing right now in Michigan. How does that sound? And because it
Sounds
depends on
great.
the state, actually. If I was in Florida, I'd probably say no to every county right now because they're uncontrolled. I mean, it's sadly, even though they're going down slightly, they're out of control. So we'll show that. I put together a little presentation just to sort of to give you the data, and then we can talk about it. How does that sound?
Sounds great.
Okay.
So 8, 10, 20, here we are. The world, what does the world look like? Well, you can see that as far as the world goes, that graph on the right-hand side really tells the story, right? I mean, we are just going, we went up fast, March to April. We had a little plateau. We went up fast from June to August. Now we're at a little plateau for worldwide cases. And the question is, what's going to happen next, right? What do the models show? And guess what the models show?
Not good, right?
Yeah, we're going to plateau for a month or two, and then October, November, December is going to be a disaster.
Oh, jeez.
So that's really, I'm really worried about November. And if you talk to most modelers right now, they're worried about November. Kind of Thanksgiving and Christmas period, I think could be a really, really bad period for the United States generally, unless we get our numbers down. And as you know, Matt, you sent me this note indicating that 159 epidemiologists signed a note saying that we probably should, kind of quote unquote reset. That really means that we would go into lockdown so that we prepare for a bad October, November. Unfortunately, we're less than 100 days away from a general election where one of the candidates really is counting on the economy to be okay. President Trump is. So we won't do that. But if we didn't have an election and I was sort of an advisor, which I am to several governments, in many cases I'd recommend a lockdown, and we'll see why. So at any rate, here's what it looks like. You can see United States and Brazil basically are a third of the world's problem. So that's not a good thing to be. And this is where we're having the big blowups. Generally the areas of yellow. So if you live in Canada right now, you are 25 times less likely to die of COVID than if you're in the United States. If you live in Europe, you are 10 times less likely to die of COVID than if you live in the United States. And that's a problem. That's a big problem because that means we can't go anywhere. Lots of people will come to us, and they'll actually dilute our problem. But if we go out as a U.S. citizen, most countries are saying, no, we don't want you. I think we can fly to about 9 countries, including, places like, Kazakhstan and places like that. I mean, it's not places you normally would go. So that's the.
Unless you're Borat. Yeah, right. Okay.
So if we bear in a little bit on the United States, right? See, visit Borat. So if you bear in a little bit on the United States, here's what it looks like. And you can see Michigan actually is caution warranted. And this is where we were back in June. Then we went into dark red for a while. Then we come back out of it. Now we're yellow again. You see the upper eastern seaboard is green. Those states have largely agreed to create a testing environment that allows them to see and manage aggregate testing, which is smart. We should probably think about joining a group like that as a state. But caution warranted means, it means basically what's happened is we've leveled off, but we've leveled off at a very high level. You'd like to be down, you'd like to be down where we were around June 15th, which is our absolute minimum. You can see on June 10th, 2 months ago, we were at 187 cases a day, new cases a day, running average. We went down to a number of 182. You really want to be at a little bit less than that. We've got 10 million. So that means about 2 cases per 100,000. Epidemiologists are they're arguing between whether it should be 4 cases per 100,000 for several weeks or 1 case per 100,000 for several weeks. But generally it's in that range. And you can see that instead of leveling off at that level for several weeks, which we would have had to do to represent what Europe has done and other successful countries have done, we went back up again. And now we're at 711 cases per day. So we've increased it by 7-fold. And our plateau is a dangerous plateau. It means that you could go up relatively easily because you've got a lot of potential community spread and a lot of endemic virus in the area. What's happened is the death rates have gone down a little bit, which is great. We've gone from 8.2% or so in the June period to 6.8%, which is good. But we're still in the lowest. We're still in the lowest quartile of performance overall for case fatality rates. So Michigan, if you're in this state and you go to the hospital after being, a case, you've got a much higher chance of dying in that hospital than in other states, sadly. You can see that the death rates generally are.
Is that because we have an older population, do you think, or what are the reasons behind that?
That's a great question. One big reason I'll get to in a second is that we're not as good as at managing our minority populations as other states, and that's a big problem. I'll show you the data in a second. We may not be testing quite as much as some of the other states are either. If you think about case fatality rate, maybe the other states have more negative results, and so our case fatality rate is a little more concentrated. It's not because we're being overwhelmed. Our current capacity is okay. We're kind of in a yellow stage of capacity, but we're certainly not like Florida or Arizona where they really are a red stage of capacity. So that's not the issue so much as I think the way we're managing our minorities mostly. The newly reported days deaths you can see are about 17 to 21 days offset from the new case rate. So what's happening here at the end right now, we're starting to hop up a little bit. And that's because you can see that we're starting to get to about 20 days, about 30 days after we started to be at our base. And we might move up just a little bit over the course of August. So August, September, the most forecasts are for a little bit of an upswing in death rate for the next kind of 2-3 weeks, but then leveling off. So we're it's a stable high death rate. And this is the issue about the minority cases. You can see that 14% of our population are for the Black population represents 30% of our cases and 41% of our deaths.
Wow.
That 41% is way off, and 30%, it puts us in the bottom kind of 10 states in the country for management. Virginia, North Carolina, Indiana, Wisconsin, Minnesota are behind us. Iowa's behind us, and there are a couple of northeastern states with very small minority populations that are also a little bit higher, but everywhere else is lower than us significantly.
Yeah, so is that lack of access to healthcare, poverty, right?
Yeah. Mostly lack of access, I think.
Underlying conditions. I mean, because
there is
for those two reasons, they haven't been going to the doctor, right? So
it's sort of like compound interest rate. As you put in a little bit of money, you get a beneficial effect. Well, the same thing is in reverse in healthcare. If you don't go to the doctor, even starting at birth, the minority populations are underweight at birth. So you start at that deficit, and this continues to compound over time with access lack and lack of insurance, unfortunately, and lack of physicians. There's some places in Detroit that have one physician for 4,000 residents, and that's a challenge to keep people healthy.
I noticed also you skipped over a chart about where not to reopen schools.
Oh, I'll get back to that. I promise. Okay. I'll go back to that because that's
okay, all right.
When you see Hispanic and Latino again, percentage of cases are way high. Percentage of deaths aren't so bad. So they apparently have probably a better access and a better outcome than our Black population. But that Black population, we've got to do something about that because that's just unacceptable. So there are a lot of people who are thinking about this. One of the issues is a lot of these populations, the Hispanic and the Black populations, are most important workers, and there are frontline workers who are essential, and we're not treating them right. That's a problem. If you look at this data anyway. So opening schools, anywhere that's orange, I wouldn't reopen. Schools in that area generally, especially if the larger schools, and if you're talking about small rural schools of less than 100 students in the school, that's one thing. But if you're talking about, you can see you know, in the orange areas, you've got more than 100 students. You're going to have one of those students with COVID who will transmit it to their friends and to the families and sadly to the teachers and staff who are at higher and higher risk. And you'll have to shut down for 14 days anyway. So what will happen is, you know, have a couple of people coming up with COVID, and you'll have to shut down. So my recommendation is to get ready, do an awful lot of work remotely, and to try to work in cohorts, try to work in you know, having Monday, Wednesday, Friday, Thursday, Tuesday kind of school days, mornings, afternoons. Try to open up the amount of distancing you're able to create. Make everyone wear a mask and hopefully a surgical or N95 mask, not just a you know a mask you make in your basement. And bring lots of hand sanitizers along and try to keep ventilation up. Right now, one of the things that's concerning is that there was a big study in Korea that looked at aerosolization, and they found that if you are simply recirculating a lot of the air through even more modern HVAC systems, that the COVID virus actually builds up on intake, outtake, and HEPA filters. So if you're not changing HEPA filters out and you're recirculating a lot of the air over and over again, as we do, especially in the winter, to try to save in heating costs, boy, we're going to have lots of problems with aerosolization and
Boy, some of the counties that are the deepest shade of red there are really surprising to me. I know the one at the bottom of the state, that's Branch County. That's a very rural county. Coldwater's the biggest city in it. It's maybe 8,000 or 9,000 people. And then the one up on Lake Michigan, I think that's Oceana County. That's also very rural. And I think the biggest city is Pentwater. That's only a few thousand people. How do these rural areas get so unlucky? You know, because you don't have the population density.
I don't know. Along the coast, I think that was because of extra traffic on the beaches and so on. Oceana was certainly a possibility to go Muskegon. I don't know down south where you see Jackson County also and then Detroit lit up. But basically, that area from Detroit up to Bay City is a hotspot area, and we've got Kalamazoo, Benton Harbor, and we've got Grand Rapids also being Kent County being hot right now. And Escanaba, that area, I don't know what happened up there. It's part of Wisconsin generally is pretty orange, and so it may be a continuation of Wisconsin problems. But that's so yeah. In these areas, what you see is you've got a lot of community spread, and the challenge when you start to then add 15% of the population, which is the population that's going to kindergarten through 12th grade, to the mix with lots of interaction. If you're very successful, the Europeans are able to keep the increase in spread down to 2 to 4%. But those areas that are out of control, it can be as high as 25% increases in spread in those areas, which would be extremely dangerous. That would give us a hard time in Michigan.
We got about 5 minutes left.
Oh my goodness. So anyway, basically you can see we're yellow, which means we're on the edge. One thing we don't have enough of is testing. We aren't testing enough to keep us mitigated. If we have breakouts, we can't identify those breakouts, and we can't control the breakouts, and we don't have enough capacity to get test results back fast enough. And so what's happened is we have a program called RADx, and maybe and the NIH has started this RADx program, and it's Rapid Access to Diagnostics. It's $250 million. Well, they have 7 programs they've moved forward, and I'll tell you, $250 million probably is enough for 2, maybe 3 of them to move forward, based on my experience in ramping up tests. And you can see most of these tests are, so the first one, Mesa Biotech, a handheld PCR technology. Well, that's a blood test. I mean, people can't give themselves blood tests. Quidel is a point of care doctor, officer, pharmacy. Again, you've got turnaround time issues and lining up issues. They have to move out of the paradigm of what's out there already and start to think about brand new ways of testing in the NIH and the government. And that means home care. That means home-based testing done with saliva, done every day, done by everybody. That's what they have to get to. And there are some companies out there. Yale just announced a test they think they can get down to about $1 a day, which is based on saliva. Stanford has one also. A company called Prediction RX is developing that test. Again, they're all solid state. They require no reagents. They go right to your cell phone. They read off the result on your cell phone, and then they can transmit it wherever you need it to go in order to give you a passport. Say, yes, this person tested negative, or this person tested positive, and here are all the different contacts they had, and please contact them. Callus, again, multiplex piece, isothermal viral RNA optical detection system under 30 minutes. But again, this is going to be nasal swab. It's going to be complicated for an individual user to do by themselves. Then everything else they're doing is lab-based. And this lab-based is the exact problem Michael was talking about earlier, which was, it took me 5, 10, 12 days to get this thing turned around. And so these lab tests that you have to send out, through the mail or through a distribution company, get the thing tested, and then come back again. That just isn't gonna solve our problem. So unfortunately, we keep making these small, that would have made sense 5 months ago, but now we're in a different situation. We got to really switch and create different policies. And we're going to look back at this time going, we just made a couple of mistakes, and these mistakes just compound on each other as they go forward.
What we need is somebody to come up with the similar to the home pregnancy test, where we all know how that works. But I mean, you get instant results, right? Wouldn't that be why would somebody not see the value in that and not be working in that, or are they working on that?
They are. They're called laminar flow tests, and GSK has a joint venture with Mammoth, who's down here doing PCR work, and those are tests that would be they're using a brand new technology called CRISPR, and that's an exciting technology, but that's not being sponsored by and pushed by the NIH. It's being pushed by GSK in order to get a pregnancy-like test. There's another group called Sherlock that has the same kind of technology and is also working on that laminar flow test. These laminar flow tests are about 75% accurate, so they're not perfect, but you can do them every day. And if we can get them down to $5 a test, then you're talking about maybe your employer would want to have you take that test every day, in order to make sure you're safe. And certainly before you take a flight, those kinds of times, you'd like to have a test like that immediately available. Even if it isn't perfect, at least you can get a better sense of whether you've got the disease than just taking your temperature.
2 minutes. So we have to wrap this in 2 minutes, Fred. So
quickly, my gosh. Well, what else do you guys want? So
vaccine. Can we talk a little bit about the vaccine progress?
Vaccine. So right now we've got 2 vaccines in phase 3 clinical tests. One group has about 45, that's the Moderna group, has about 4,500 people have already been enrolled. They've already taken their first shot. And Pfizer is the second one. They've got about slightly over 2,000 enrolled in their phase 3. They got to get to 30,000, right? They got a ways to go, but we think that by October they'll have that 30,000. Then they have to wait and get a second shot, and then you got to go out in the environment and see whether or not the placebo guys, the guys who just got the water, get the same amount of test or hopefully more of COVID than the other. And what happens is you got 30,000 guys all going out there, and maybe 20 of them come back on the placebo side, but only 10 of them come back on the with COVID on the active side. That means you've got a 50% benefit, and that means the FDA will give us the approval for that. But it's going to take till certainly after the election, certainly after, I guess we'll have some kind of March time frame.
Okay, we're going to have to leave it at that. We'll get you back on the show next week, and we can do a follow-up on some of this stuff. One of the things I want to have you talk about is I saw a study on masks. There was 14 different types of masks you can get. Which one's the most effective? We can cover that next week.
Absolutely.
Yeah, let's do that. I'm curious about that one myself.
Yes, we'll do that. I'm looking forward to it, because that's a big piece. A mask is not a mask is not a mask. There are different capabilities that these masks have, and it's important that we start to move up the scale to get to 4 to 9. But apply for everybody. Right now, we're supply constrained is a problem.
And
all right, folks, we'll come back here at 2 p.m. Eastern time next Monday, and we'll talk about mask effectiveness.
We'll do it.
Look forward to it.
And if you want to check out Fred, he's at fredbraun.com.
Traditional four-year students love Lawrence Technological University's thriving campus life. But LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.